Thank you, Professor. Good morning, good afternoon, good evening. I'm Graham Chisholm. I'm Head of Policy and Learning at THET, the Tropical Health and Education Trust. In my presentation today, I will take the United Kingdom, the UK, as a case study on ways that a high-income country may play its part in contributing to sustainable workforces in low and middle-income countries, as well as in high-income countries such as the UK. Just first, a couple of words on THET. We're a global health charity. Our vision is a world where everyone has access to healthcare. We support the training of health workers in low and middle income countries. And it's through the health partnership approach that we believe we can make the greatest difference. And indeed, that's our mission, to work in partnership to support health workers across the world. We view health partnerships as a model to improve health services, very much based on the ideas of co-development between individuals and institutions from different countries. And so our health partnerships celebrate reciprocal learning and mutual benefit. And in practice, these health partnerships that we engage in are typically formal long-term relationships between UK health institutions such as the hospitals, universities, professional associations, and their counterparts in LMICs. And there's actually over 300 in existence across the UK, linking this country to many countries across Africa and the wider world. And we implement our own country programs in many countries, and we also manage grants to facilitate partnerships between the UK and LMICs. We also have a growing what we term policy and learning capability, which is increasingly allowing us to gather evidence from our work to help us to learn as an organisation and to influence others on such matters around health system strengthening and, of course, health workforce. Now, and so we recently held a public inquiry looking into the relationship between the UK's National Health Service, the NHS, and low and middle income countries' health systems through the lens of an increasingly mobile health workforce. And the resulting report, From Competition to Collaboration, tries to set out the ethical considerations for a country like the UK in an era of health worker mobility. We conducted literature reviews, semi-structured interviews, and with 28 key informants, 13 from Germany, Republic of Ireland, Norway, Switzerland, and the UK, and 15 from Uganda and Zambia. We conducted a qualitative survey to gather information on the experiences of health workers practicing in the UK who identify as members of our diaspora. And the guidance was provided by a steering group of leading figures in global health. In terms of context, in low and middle income countries where THET is active, the effects of underinvestment in health workforces, I think, is frankly stark. And at the same time, the UK has also struggled to maintain health workforces since the NHS came into being in 1948. Albeit at a very much, of course, lower order of magnitude. In many ways, the UK has relied on health workers trained elsewhere. And in fact, the UK has one of the highest levels of reliance on internationally trained health workers of any OECD country. 1 in 3 doctors, 1 in 8 nurses in the UK were trained in another country. The UK's NHS has set out plans to increase international recruitment significantly. But all this assumes that the UK can continue as it has in the past to attract more and more health workers from elsewhere to solve its health workforce crisis. But the UK is both a destination and a source country for health workers, a beneficiary, and if you like, a victim of increased mobility. And the decision to leave the European Union has already had a profound impact on the desirability of this country as a destination for health workers, especially those from the EU. And the effect of this decision are already being felt. This begs the question: if health workers aren't coming from Europe, then where will they come from? And this takes place in the context of increased competition for health workers between the UK and other high-income countries. So we argue in the report that the UK therefore has every reason to be one of the first high-income countries to recognise that there are no winners in this escalation in competitive international recruitment. And so we explore the measures we need to take to stop practices that exacerbate inequality and poor health outcomes in LMICs. So in the report, we make a sequence of recommendations aimed at health workforce policymakers in the UK, as well as in LMICs. And the recommendations come in three clusters around ethical leadership, ethical recruitment, and ethical partnerships. In terms of context for our first ethical leadership recommendation, we feel that there's insufficient policy coherence, certainly at the UK government level, between NHS international recruitment strategies that encourage health worker migration, training opportunities within the NHS, on the one hand, and ODA, official development assistance, used to strengthen health systems in LMICs on the other. The risk, in essence, is that there remains a danger that the UK gives ODA with one hand, whilst taking away health workers from LMICs, be it passively or otherwise, with the other. And so we call for government to play a leadership role in this process, and we feel that this approach would help support health workforce sustainability that benefits both LMICs and the UK. And areas of particular focus of this strategy, as highlighted by many low and lower middle income countries in the third round of the WHO Global Code of Practice on International Recruitment of Health Personnel, should include support and developing policy to regulate the migration and retention of health workers, promotion of policy coherence in countries and regionally which is supportive of sustainable workforce planning that addresses push factors, and measures could include diversifying skills mix to harness the potential of community-based health institutions, could include developing non-wage retention strategies, including improving working conditions. It could include support in developing, implementing and monitoring bilateral agreements. It could include support in strengthening data information systems to address data management gaps. And over recent months, we're hearing that the UK is indeed moving towards developing a new overall global health strategy. So we see now as a good influence moment for the health workforce elements of this emerging strategy. And within the context of ethical leadership, we also feel there's a risk that all the education and experience that healthcare professionals from LMICs gain when studying or working in the UK is not capitalised on when these healthcare professionals return to their countries of heritage. In terms of context for our second main ethical leadership recommendation, we make the point that LMIC governments also hold responsibility for educating, training and employing sufficient health workers for the needs of their populations. So we call the Ministries of Finance and Ministries of Labour and Employment, as well as Ministries of Health, to focus on addressing this issue. However, we also acknowledge that LMICs can't compete with high-income countries on remuneration and opportunities for specialised training necessarily, or research for that matter. And so emphasis should also be placed on other tactics around developing non-wage retention strategies, harnessing the potential of community-based health workers, promoting a triangular flow of talent and skills, and investing in strengthening national institutions for tracking internal and international migratory flows, very much in line with the Global Health Workforce Alliance and WHO analysis. We then have our second cluster of recommendations, that of around ethical recruitment. The headline really here is the risk is that recruitment codes of good practice are being flouted. And so in the report, we emphasise the need to strengthen the implementation of the UK Code of Practice and strengthen implementation of the WHO Code of Practice on international health recruitment. So it's good to see that earlier this year, the UK has now revised its own code more to align with the WHO code, as well as to try to tighten up the code to avoid malpractice. The final cluster of recommendation focuses on ethical partnerships. Now in THET, our experience, ethical partnerships are a really powerful ways of maximising the synergy between official development assistance funding aid, which benefits LMICs, and NHS investments that ensure delivery of services in the UK. So in concluding the section of the report, we survey the different ways in which the UK can encourage not only outward but inward mobility within the context of an evolving ethical partnership landscape. Our recommendations directed at the UK are, that the risk question here really is, do these train and return schemes actually benefit lower middle income countries? So we feel that there's a lack of clarity on how the design and implementation of current train and return schemes benefit LMICs, and there's a lack of coordination in tracking the professional progress of LMIC health workers who train in the UK. We think this is undermining that synergy between ODA funding and NHS investments. And so we make the recommendations around, well, we need to evaluate such programs. We also need to engage other stakeholders in the development and implementation of them, trade unions, regulators, professional associations, international partners such as WHO as well. And if we can get them right, then there's no reason why we can't consider scaling up ethical programs that actively encourage de facto circular mobility of health workers, which include ethical improvement outlined in the report. Now, since the report was published, we've embarked on further exploration of training and education programs between the UK and LMICs with a sequence of what we're terming Sustainable Health Workforce Symposia. A most recent symposium examined practical interventions that are being used to increase government-to-government collaboration on workforce migration. Now, speakers at the symposium provided case studies of some of the ways the UK has engaged with other countries on workforce development. And each case study offered examples of how ethical principles are increasingly being applied in practice to ensure that LMIC health systems benefit and that the health workers' rights are respected. I'll briefly share one case study of a country, not in Africa, but the ideas that I feel very pertinent and applicable to that context. And we heard from the UK's Department of Health and Social Care on how the relationship between the UK and this lower middle income country encourages employment of nurses and other healthcare professionals from that country to the UK, and how it has matured into an ethical partnership with gains for the sending country, and not only in terms of remittances. Now, the lower middle income country has prioritised employment, including overseas employment, as part of the Constitution, which provides for the state affording full protection of labour, local and international, organised or unorganised, and promoting full employment and equality of employment opportunities. Now, it's structured its migration in such a way that ensures the safety of its nationals working overseas. The UK government works closely with this country's Department of Labour and Employment and the Ministry of Health to sign a memorandum of understanding. And the recruitment agencies operating within the lower middle income country and the UK agencies heavily engage and authorise each nurse to carefully check their background to protect both sides. The lower middle income country government also regulates the numbers going out at a given time, so they cut or increase the numbers as and when necessary. Furthermore, nurse training in the lower middle income country is not funded by the government, but relies on private tuition fees. And this has resulted in the lower middle income country developing into a regional training hub for nurses who are considering international careers. For example, a recent study has shown that for every nurse recruited into the US health system, a further 10 nurses were recruited in that lower middle income country. So this approach seems to be benefiting LMIC health systems, not simply the economy through remittances. Just a few final words. We've also drawn out the following key learning points from that sequence of recent symposium. So these points summarise some of the key considerations stakeholders from both the UK and LMICs should consider when developing training and education partnerships that include migration of health workers and address the issues around HRH crisis. Firstly, benefits for all can be achieved by ensuring training and education programs are mutually beneficial and that the shared governance is underpinned with principles such as transparency, accountability, co-development. Such principles must be measurable using key benchmarks of quality for partnerships and the migratory relationship within such partnerships. And the governance of health workforce is also of vital importance. The Kampala Declaration, Gender for Global Action, calls for building leadership for health workforce. And there's a continued need to popularise the report and reporting on the WH Code, asking countries to report every 3 years, of course. And coordination, not only between the UK and individual countries, but also at the regional level, is also important, especially as workforce mobility within regions. And the role of diaspora health workers should also be formally recognised, harnessed, encouraged, in particular for supporting education and training programmes. And of course, the COVID pandemic has emphasised the need for, amongst many other things, education and training to focus on strengthening public health workforces and leadership, especially community health workers. More broadly, the pandemic has highlighted that shifting nature of health workers' roles beyond physical care to also encompass mental and social well-being, fully reflecting the broader social determinants of health. And has also highlighted the power of virtual engagement, of course, but also the need to ensure the measurable quality of such an approach. I will conclude there and thank you for your time.
Thank you, Brian. It's quite a lot of stuff, and thank you for that effort which your organization is making. Let me now come in and give you sort of an overview of the crisis, and I will use some slides here, which will help us to go through the conversation. Are we doing that? In the next maybe like 10-15 minutes, I'll take you through this. Some of you may have seen this some of these slides before. I think we start here. Do we care about the health of the people of the world? And if we do, what are we doing about it? And we need, at the end of the day, to create a climate of opinion which makes access to life, access to responsive health systems, something about which the world galvanizes together, like we created movements that defeated apartheid, slavery, and so on. It's as big as that, because right now in our part of the world, children die of malaria, they say God called the child. A woman dies in childbirth, they say, oh, it was her day to die, and so on. Yet we have resources in the world to make this change. So that is what the whole business is about. It is about social justice. It's about equity in a global world where we are interconnected and have enough resources and knowledge to make that different. And the crisis is anchored in the following: populations living longer in the north, wanting and expecting and being able to pay for health care, disease burden in the south getting worse. And then there is a shortage. It's estimated by WHO that there will be a shortage of 18 million by 2030. And then this topic has been neglected over a long time. And this is about populations. That's Japan and Uganda. Japan has got the older people. Uganda has a lot of young people who are dependent. This is what happened with HIV. Life expectancy in those countries just plummeted. And the response, particularly following the African health ministers' efforts at the World Health Assembly, are getting resolutions on this topic against the run of the meetings without even these items being on the agenda, major quarrels in some of the meetings, and eventually the Joint Learning Initiative, paid for by Rockefeller and chaired by Lincoln Chen, wrote a report which shone a torch on the problem. And it also joined the high-level forum on health MDGs. A World Health Report was written in 2006 on this topic, working together for health, which identified 57 countries in Africa with shortages. There were 2 meetings in Oslo, and at the end of the day, the Global Health Workforce Alliance was launched. And we have since had Global Health Workforce Forums, number 1, 2, 3, and we are waiting for a 4th one to happen soon. And according to J.W. Lee, who was there as DG of WHO, he summarized the whole agenda as our job to ensure a motivated, skilled, and supported health worker for every person in every village, everywhere. That's our job. Those are the 57 crisis countries in Africa and some in Asia and South America. Africa, 25% of the disease burden and very small number of health workforce. Now, some milestones on this crisis. We held the first global forum on human resources for health in Kampala in 2008 with the Kampala Declaration and Agenda for Global Action. And then the code, the WHO code on the international recruitment of health personnel, 2010, is a major one. And then there have been studies in Africa here, Subsaharan African Medical Schools Survey, which established that there's a huge capacity gap in the medical schools. And we have had many other meetings taking place, including the nursing campaign, which the year of the nurse 2020, which spilled into this year. Along the way, the HRH department at WHO was closed in the middle of all this, 2010. It opened 3 years later. Can you imagine? In the middle of a crisis, they did that. So these are some of the key milestones on addressing the crisis. And these are the major challenges: leadership, lack of intersectoral collaboration, and sustaining partnerships, the global health initiatives, which focus on like HIV or TB without realizing that you need health workers to do this, and low expenditure on health. Sometimes the health, until a long time, was just classified by those economists, World Bank, IMF, and so on, as just a consumptive sector. But that also is changing now. The crisis in Africa has persisted. African health workforce densities are still low. So the crisis is still there, and it's got worse in some of the countries. And here we are basically saying in this slide that while the world will have that 18 million shortage, Africa will not be able to employ the health workers they need, while the richer countries will be able to do so. That's the part of the crisis. What can we do to succeed? By far, the single most important intervention is political will, political commitment, and then good governance. Then capacity for workforce planning inside countries, planning long, acting short, having strong departments for health workforce in the countries, either Ministry of Health, Ministry of Planning, and information on health worker movements. Where are they? How many are going in training? How many are coming out? Where are they? What's the labor market like? So those are the key critical success factors. We now have the global health workforce was wound down and has been replaced by the Global Health Workforce Network, whose objectives are similar to those of the Alliance to create a movement around this. But I have issues with this because it is under WHO. And WHO, the Global Workforce Secretariat was in WHO, but was governed by a board which was outside WHO and could speak and say things which today the Global Health Workforce Network is not able to say, and WHO has got limitations. I still am advocating for an adjustment which will create an institution which is able to speak freely and without any fear of recriminations, as WHO has got some limitations. And the new movement going to 2030, we want to do things in a different way instead of the same old ways. Health workers being seen as an expenditure, as an investment. working together, not fragmented, increasing efficiency, having better data. And here we are now part of the SDGs, Health Workforce number 3. Target number 3 is increasing health workforce. There it is. And this is also big. As he was leaving UN, Ban Ki-moon established this group, the UN High-Level Commission on Health, Employment and Economic Growth. It was co-chaired then by France and South Africa. And it is the one which came with that recommendation that health workforce is an investment for the community. It creates jobs. It has the health economy itself is important for countries. And then here is our global code on the international recruitment of health personnel. I don't need to say more about it except to emphasize that the code is just beautiful. It took a long time to negotiate it, about 4 or 5 years, but now that we have it, it takes care of individual health workers who move around. It addresses the needs of sending countries, of receiving countries, and provides a framework for sharing a global pool of trained health workers. So the code is something we really need to advocate and support. There are only 2 codes adopted by WHO. The other one is on breast milk, and this is another one. Immigration is increasing. Full stop. But there are provisions now through those tools for orderly and safe migration. And there are structures. ILO, OECD, WHO have a platform on health worker mobility, which we should be using, all of us. I'm basically summarizing here by saying that the tools exist for implementing the code. The structures and the tools are in place. Let's use them. There you are. This is another tool, Global Compact on Safe and Orderly Regular Migration. The tools are there. It is not binding, but it is there for use for those who are interested to contribute and solve the crisis, the global health workforce crisis. We've really moved quite far from where we started like 20 years ago. Yeah, so I've already spoken to this, why the Global Compact is about build global skills partnerships amongst countries that strengthen training and capacities, national authorities, relevant stakeholders, or the CCF country structures which bring all the partners together and preparing trainees for employability in markets that have been identified. Here we are now. How do we train and get these people to be able to move around? So there is a global health workforce accreditation mechanism which needs to be developed, and it is there already, but it needs to be strengthened through partnerships and through it should be that network should be helping towards this. But I told you I've got issues of the network. There is no single entity that can accredit all medical schools, but there is a way in which it is being worked out. So these are those who are examiners, World Federation of Medical Education, ECFMG. They are there and they are all set to go to be able to create accreditation mechanisms by regions which can enable portability of health workers from country to country. I'm ending now with this message. I would like to call upon the world to prioritize health workforce as a global public health good by all the governments, global health initiatives, civil society, private sector, all of us, if we want to achieve SDGs. I'm calling for support to fund advocacy for the code. The code is the tool which we have. It's an excellent instrument. Then, using the code, using bilateral and multilateral agreements, let's educate and share a global pool of skilled portable health workers through these accreditation systems and the code which I have described. And we want to build strong national and regional institutions, as well as global institutions, which can organize and make all this happen, using, of course, technology and AI. So that's really my message. In summary, I'm saying that there's a global shortage of health workers, and it is structural. We can't run away from it because the North is aging, the South has young people. Let's train and share them. Let's create structure. The world has moved from neglect. It has now created structures for us to be able to work together to solve this problem, using the code, all those mobility platforms and so on, ILO, IO, and so on and so on. So we are ready to go. But what is lacking is funding to make those things happen. Funding to advocate for the code. Funding to strengthen health workforce departments in countries at regional level and at global level. So that's my message. Thank you very much indeed for listening to me. And I will now invite Vanessa to go deeper into how we can make all this happen. So Vanessa, over to you.
Thank you, Professor, and thank you for giving me that challenge to rise to. You know, I actually, I'm deeply honored to follow both Graham and you as well in speaking, in part because I'm deeply admiring of the advocacy, the work, and really kind of the actual concrete forging ahead of defining what the challenge is that we face in this moment. And so that both of your organizations have done. And it was interesting to hear you speak, Professor, and I'm not going to be using slides today, forgive me. But it was interesting to hear you speak because I think I'm going to echo in some senses many of the same messages. Because we are really gathering in a profoundly existential time. And there are very deep challenges that we are facing today, beyond just the outline that you've given Professor Maswa of the long struggle to invest in the healthcare workforce and its needs, and the very undulating path we've taken when still not investing the amount that we need to. But we are now confronted by growing challenges that I think really question sort of the values by which we as a global community are investing. And this is for me fundamentally what is the root problem in why we have not yet invested in the health workforce. But today we are, we are looking at climate change, which is altering the communities and the resources that we have available. We are witness to and often participants in as a global community growing inequity gaps that are creating tension. And we're now today facing a global pandemic that is ravaging our world and reflects what I think is a deep underestimation of the importance of health and is profoundly spotlighting the social determinants of and access to health that have pre-existed the COVID pandemic, but are being made worse in this COVID pandemic. And I think that we just have to start from a very fundamental place that there's an essential opportunity for us to rise to this occasion and to redefine values for our sustainability and well-being. And this has certainly been the focus, I know, of some of our work in our day-to-day, of those of us who are on the panel now, of the day-to-day that we do in terms of just trying to shift the change of people's understanding of the power and importance of the healthcare workforce. But I want us to take this step back to just this very fundamental place, because I think we just have to start from how do we want to live and what do we want to invest in and what actually matters? Because I think if we go there, we will find that investing in health, investing in a sector that creates jobs, that creates gender equity, that provides adequate health care and sort of all the positive effects that come after that makes an incredible amount of sense. But it's also going to take a shift from us realizing that there isn't just an economic bottom line, because as you point out, Professor Maswa, in your remarks, we always see healthcare workforce as an expenditure. What does it cost? We don't actually see what we gain. And so I think it's important for us to start to shift this. And this idea of shifting values is not new. It's actually the work of the several economists, which is important to realize that this is rooted in an economic argument. But Joseph Stiglitz and Amartya Sen have all argued for the need to sort of change the metrics by which we define our success and to look to investments and outcomes in education, in health, the environment, the quality of life of our citizens. And this has been a slow march towards this sort of argument. But in 2021, in a global pandemic, facing the healthcare shortages we see, we cannot afford actually to go slowly at this point. And this has been very much the work that See Global Health has focused on, is to support this particular agenda through the investments of the healthcare workforce. And it turns out that health is fundamental, not just to our individual ability to survive and to thrive, but really to our collective well-being and the stability of our communities. And so there's growing macroeconomic data that has shown this about the importance of health for our national growth. Investments in health have been shown to increase GDP by up to 4%, and nearly 1/4 of growth in middle and low income countries from 2001 to 2011 grew out of improvements to health. And this matters because when we're making the argument, or governments or international finance institutions making the argument it costs too much to make these investments, we actually have to realize that these are fundamental investments for a path to development, a path to economic growth, a path. It's not a question of what does it cost. It's actually a question of how much is it going to cost if we don't do it. The data is there on a microeconomic level. One of my favorite studies is a UNDP study that showed that in Zambia, when the main breadwinner of a household dies of HIV, 2/3 of those households actually experience an 80% decrease in income. 61% have to move to cheaper housing. About 40% lose access to running water. 17% of boys and 21% of girls actually drop out of school. We also know that better health leads to more income, less lost work days. And the ILO came out with a study that showed that ill health and health shocks have actually been shown to increase the probability of leaving the labor market by over 50%. And that even 2 years out after that health shock, people still have not recovered. But if there's really any doubt about the importance of our health and our need to invest in it, COVID has really provided the incontrovertible proof. Because we've discovered exactly how critical health is to our daily lives, how poor health worsens pre-existing inequity. I am based in the United States, where we have seen that there's a disproportionate number of cases and deaths among Black, Latinx, and Native Americans. We've seen the disparities play out over vaccine distribution today. In Uganda, for example, there's been a horrible surge of COVID, where we know that healthcare workers have been dying, who've been on the front lines of responding to the pandemic. We've seen this also in the other partner countries where SEED works, with growing cases in Malawi, in Zambia, in Sierra Leone, and many places in the region. So what we're really facing in this moment is a very existential decision about whether we are going to invest in our future and if we are going to invest in the healthcare workforce and people. And at every level, it is critical to realize that healthcare is a human-centered intervention. Whether you are a patient who is vulnerable in receiving care, or if you are the caregiver who's on the front line of responding to COVID, to HIV, to maternal mortality, healthcare workers are really at the heart of a health system. And they are the ones who walk the halls, who deliver the medications, and who can leverage technology to be able to bridge those gaps. As you heard, there's a global shortage of 18 million doctors, nurses, and midwives expected by 2030 if we don't meaningfully change how we're investing in the healthcare workforce. These shortages are worse, as you heard from Dr. Maswa, where the disease burdens are highest. And what this actually translates into really real numbers is that for some countries, this means only one doctor or a handful of nurses for every 100,000 people. In Liberia, for example, in 2014, before Ebola hit, there's only about 300 doctors in the entire country for the population, and many of those ended up dying in the Ebola response. And part of the reason that outbreak and part of the reason COVID is happening at the rate and speed it is happening is because there is not enough healthcare workforce to help respond to these crises and be able to sound the alarms and to mount the response. So these shortages actually translate into very real health outcomes and impact. 99% of maternal mortality occurs in lower and middle income countries. 80% of non-communicable disease deaths are happening in lower and middle income countries. And today, still about 75% of the HIV disease burden is happening in lower and middle income countries. But what this really is an unnecessary vulnerability in the face of COVID today too, and that there's inequitable rates of death and suffering. In fact, the need for the healthcare workforce is actually a significant barrier to our ability to scale up vaccines. For every $1 of vaccine donated, another $5 is needed for delivery. And $2.50 of that needed cost is actually to train and support a healthcare workforce able to deliver the vaccine. And what we've seen is that many cases, as vaccines are being delivered to countries, there's a requirement to pull healthcare workers from other needed and essential sectors in order to deliver that vaccine. Data has repeatedly shown that the disruption of essential services in crisis or conflict actually causes more death in the decade after that crisis or conflict than the crisis or conflict did itself. So not only are we looking at millions of deaths in COVID today, but we are going to be looking at decades worth of death and suffering because of our failure to have made these investments before. I don't know how many of you heard Dr. Tedros and I'm sure most of you did in his remarks last month, that 115,000 healthcare workers have died during COVID. The scale of this loss of 115,000 healthcare workers is probably poorly understood by most outside of this conversation. And to be fair, the number pales to the close to 4 million who have died around the world from COVID, or to the estimated 225 million jobs that have been lost globally, which lead to hardship, insecurity, and suffering for millions more. But 115,000 is actually a deep underestimation to the loss of the workforce, with scant reporting, increasing burnout and attrition right now. And so we're probably looking at even worse numbers as we come through this pandemic. And these deaths, while deeply damaging in and of themselves, is not just a loss of individual life. It represents additional years of training. If you do the calculation, you assume training a healthcare worker takes on average 10 years when you go through the entire pipeline of pre-service training and in-service training. That's millions of years of lost training. It's a loss of public investment. It's lost knowledge and experience, which costs money and quality to replace. And it's an exacerbation of this already existing and growing gap that we face. And the reality is that we face two standards of care in the world. You heard about what's happening in the global north versus the global south. We already know that there's deep inequity. But we are looking at a future that shows increased risk of inequities through pandemic outbreaks, economic and political instability, and really a creation of a cycle of foreign aid dependency if we don't build this capacity in the places where the disease burdens exist. This year has been declared the year of the health and care worker. And I'm incredibly grateful, and so are all of us at Seek Global Health, that this has been designated this, and there's this attention to the sector. And I joined the WHO, Dr. Maswa and the many colleagues, to urge a need really to go beyond this applause for the healthcare worker in this moment. We absolutely have to have action. We've heard a lot about what the problems are, and I'm very appreciative of my colleague at that, sort of outlining some of the policies, as well as Dr. Maswa for some of the policies that are going to create the meaningful shift. But I want to just say that for me at Seek Global Health and my role, I'm a physician, and I've spent the last year working in the front lines of COVID and those that are critically ill. The reality is we need to just fundamentally decide that we're going to mobilize the capital, the resources, the time, the patience, and the investment to train more healthcare workers. Because while the policies are helpful to create a community around healthcare workforce migration, and while it's incredibly important to think about our roles in pulling healthcare workers, and it is critically important for us to think about how do we support those that exist and retain them, the reality is we still need more. And the data on the health workforce investments has grown, and it is clear. It does not need to be an either-or approach. We need those sustainable policies, but we also need to put more money. And it's important to realize that not only are investments in the healthcare workforce really fundamental to health system strengthening, resilience, and responsiveness, but these investments actually spur economic growth. They create jobs that are more resilient during recession. The healthcare sector is actually up to 17% to 20% of most economies, and creating those jobs can actually grow those sectors and create the possibility of greater economic growth in these countries, as we've discussed. And data has repeatedly shown that the return on investment in the health workforce is significant, on average generating a return on investment of up to 9-1. And according to the Uganda Bureau of Statistics in 2019, the 30-year return on investment for the health workforce is a whopping 51-1. Investments in the health workforce are also essential to gender equity. Almost 4 million women make up close to 50% of the global workforce, contributing $3 trillion to global healthcare globally. Nearly half of this care is unpaid. And the WHO has actually noted that equal participation by women in the global economy would result in nearly an estimated 160 trillion increase in global GDP. That is more than enough to afford a sustainable healthcare workforce investment. So we are actually truly looking at a question of choice.
Vanessa, just consider summarizing. Beautiful.
Of course. Thank you. So I want to just say that for us at SEED, this is critically important. SEED Global Health has spent the last 8 years working with governments in order to train healthcare workers to help fill those healthcare gaps, to both try to help increase the numbers, the pre-service and the post-service pipeline, and to help retain them. And we've helped train over 23,000 healthcare workers who've been built over programs that have built over multiple years, like those created with the government of Uganda and Lyra University. We've now helped, for example, graduate over 90 midwives that serve the country. And of the 32 graduates, for example, in 2019, all 100% are employed, and about 90% have actually continued to work in the public sector and maternal and newborn facilities. In Zambia, we've seen the power of healthcare workers not only respond to COVID, but to protect the essential services that are necessary for in birth and childhood mortality throughout this pandemic, and that versatility of the healthcare worker has been essential because we can not only address the pandemics we face, but we can protect those essential services with these key investments. And that really, there's a profound ripple effect that if you focus on training a qualified healthcare workforce, you can not only provide better and higher quality care, which is the leading cause of death in the world today over even access, but you can actually create the ability to train across the health sector and across generations and really create agents of care, agents of change in a health system. And so the work that we've done at SEED is to really invest in that and to marry the efforts that we have done on the ground to help create this policy argument for what this critical need is in this moment. Because we've seen it every day through our work in the last 8 years. And I'm honored to join you and to kind of really create, hopefully, an argument for the urge, not the either or, but the need to really make this a yes and the power of this investment that is critical in this moment. Thank you.
Very good. You've taken us all the way from our foundations, our values, to the practicalities of, so let the conversation start with the next statement from the private sector. Patrick, introduce yourself briefly and make your presentation. And mind the time. You are muted.
Yes. Okay. Now I'm no longer muted, I guess. So thank you so much for having me on this discussion. It's a privilege for me to be here. Very good day from Dubai. I'm based here at the headquarters for the region, Middle East and Africa. I'm the country manager for Uganda, for Ethiopia, for Siemens Healthineers. Now, before we go into the matter and the discussion of today, I'd like to present you in a few slides who we are and what Siemens can represent. Siemens Healthineers is a subsidiary of Siemens, the big German company. We're independent and we're listed on the Frankfurt stock market. The company has its headquarters in Germany, and it's fair to say that Siemens Healthineers is a significant player on the healthcare industry. We bring the power of a global operation, having major factories in countries like the US, countries like, of course, Germany, but also Spain, Korea, China, etc. We are market leader in most of the businesses that we're active in and in the countries that we work in. And with 14.5 billion revenue and $3.2 billion revenue, we are one of the leading companies in the industry. We make a split here in the revenue, as you see, because partly it is what we report in euros. The rest is because there's recently been an acquisition of Varian, which is the market leader, as you might know, in cancer treatment, cancer fighting, which had a big impact on our company. We're now 66,000 highly skilled employees, and we invest a lot of our revenues in R&D, so in research and development. And this leads to no less than 22,000 technical intellectual property rights, of which 40,000 are granted patents. More than 70% of critical clinical decisions are influenced by the type of technology that we have in our portfolio, and we're proud to say that more than 90% of the leading hospitals worldwide collaborate with us using our equipment and solutions. Let me get back quickly to what I said about Varian, and this is a really important event that was marked in April of this year. By joining forces, we can now address the complete clinical pathway from early detection, diagnosis, therapy, and monitoring, and of course, the patient aftercare. And together, we can take a significant step towards our joint vision of a world without fear for cancer. So this is a very important step that we took. I'm not going to go too deep into this slide, but I would like you to understand what our portfolio is about. We have a unique position in the industry for the moment. Of course, most of you know that we are diagnostic imaging, CT, MRI, X-ray, let's name it, ultrasound, advanced therapies, lab technologies, point of care, and of course, Varian, as I just named it. All is supported by our customer services, and this is a vital element in the success of our company, that we have a big access to customer services through our presence worldwide. Now, to come back on this presence, if I come to Africa, we work mainly with local partners, and for Uganda, for instance, we have identified two very high competent partners, which are Elsmet and Pacific Diagnostics, and they are in fact people that help us providing the services and application training to people on the ground, to our customers. So this is an important thing for you to know, I think. And we're proud to be able to offer a unique portfolio of innovations to healthcare providers around the world, of course. Now, if we come to the topic of today, we see that the increasing shortage of skilled workers and the growing need to secure reputation of the healthcare providers represents a real dilemma for all of them. On the one hand, they need to attract, retain, motivate skilled professionals. Also, they need to ensure a seamless start with new equipment. If they have some new equipment, it's important that it will be used to its full potential from day one. They also would like to expand their clinical capabilities over time and capture also some additional revenue. They need to position the institution as a provider of choice to patients. And of course, important also to protect the investment at predictable costs. Now, these are some of the major pain points that our customers are facing when it comes to application, training, and education. And the question is, do we have a solution that addresses all of these challenges that our customers are facing? And the answer is yes, we do. And these will be addressed with education plans, as we call it. You can ask yourself, why does Siemens Healthineers care about health workforce? We are, as a manufacturer, of course, of medical technology, concerned about the lack of healthcare staff. And yes, we are. The answer is quite simple. Why we are? Because we want to serve our customers and patients by providing safe, reliable medical technology, and we want to support physicians, radiographers, nurses with technology that is easy to handle and allows to make accurate diagnosis, decisions that can save lives. And our main concern is that our equipment is used optimally for the benefit of the patients. And this requires proper handling by the personnel, of course. We sell equipment that offers incredible performance, amazing information, but too often we see that the equipment is not being used to its full potential. Through my experience in Africa, I've seen many times people asking for let's say, a 3 Tesla MRI system in the first place, rather than going to a basic system like a 1.5 Tesla system. People sometimes think, well, the 3T system might be better because it's more expensive, it's got more features. This is not necessarily the case. It depends on the procedures you want to do with it, of course. So I would say, to keep on this example of the 3T system, it's complementary to 1.5, and rather invest in a basic system that can already do a lot of the procedures, but invest in the service contract and of course in education. And this is where we try to help you also as a manufacturer. Now, looking at this slide, there are 3 stakeholders, in fact, that face different challenges. On the one hand, we see, of course, the hospitals that have a lack of skilled resources, under usage of the technology, not being used to its full potential, inefficient diagnosis and treatment, and limited patient satisfaction. So these are the main elements that the hospitals are facing. On the other hand, there's education institutes. There's a lack of education on medical technologies. There's mainly in Africa missing bachelor, master level curricula. And let's face it, some of the EU programs also failed here to help. Now, in the industry, we're also facing challenges, of course, because we find it difficult to train the professionals. There's a hampering growth, and in the end, it gives a bad image on the market. Now, what do we do to meet the need for qualified staff within Siemens Healthineers? Now, we start, first of all, by collaborating closely with our customers, which are the hospitals, the healthcare centers. The training measures of their staff need to be identified, and we help in doing so. And together with our customer and our local business partners, we check which kind of knowledge or technique is missing. Then we design and we conduct training measures together with our customers. And these could be either online or on site. And therefore, we have developed a platform which is called PEPconnect, which allows customers to offer individualized online and offline courses for their staff 24/7. We also have smart simulators that allow to experience virtual hands-on scanner proficiencies. We have smart remote services where we connect the system to our headquarters and where guidance is given by experts of the company to the users. Now, this is an interesting slide, I think, because it just reminds me, when do we learn and remember? And only 10% of what we read, we really learn and remember from. So this is the passive learning, let's say. 20% of what we hear, we learn and remember, and this goes up if we see it. If we see and hear it, already 50%, but it's only active when we say and do that we get to maximal learning. And that says why we need a holistic approach towards learning. This is the reason why we at Siemens would like to approach this really holistically and have a huge portfolio in education and training for our customers. I'm not going to go deep into this slide here, but again, as I told you, this PEPconnect is a very interesting service, and I would like to encourage all of you to go and discover it for yourself. It's a true virtual experience, and we have, in fact, PEPconnect and PEPconnections. PEPconnect is a free service. It allows people to explore and engage in vivo and in vitro learning activities. It includes e-learnings, webinars, job aids, videos, virtual instructor-led events, and a lot more. You can create your own learning experience with an individual profile. You have a plan, a transcript to record your educations on. You can connect, you can communicate. It's in fact a social platform, a social learning group. This is a free service. It's open to everyone. I will share the link in a few minutes. with you. On the other hand, we have PEPconnect, and this is more oriented towards the institutions. There you can personalize the education experience of individual employees. You can assign, create, manage education of entire groups, communicate within the groups, share information. This is a subscription fee, and which is very modest, I must say, but we can help you if you're interested in this, also through our partners or directly by contacting us. But this is a great initiative, I think, that shows that we care really about education and about the workforce crisis in worldwide, in fact. So if you're interested, this is the PEPconnect website. So go to siemens.com/PEPconnect. Explore what you can find there. There's many topics. There's 6,000 different topics you can find there, videos, etc. You can create your own personalized learning plan and engage with others. So this is just one example that we do to and show that we care about learning, about education, about using optimal hour systems. Another example is the smart simulator, and this is very interesting if you want to train a bigger group of professionals without the need of having to block and install equipment. It supports the training of radiologists, radiographers prior to uptake of new equipment in the hospital. So before the equipment arrives in the hospital, people are already trained, and of course it shortens the time also for the training. You do require some classroom with desktops, some screens, internet connectivity, of course, but we can also help you in getting these set up. Yeah, I already heard the number, of course, of 18 million, so I have to update my slides. 15 million, 18 million. Anyway, it's a lot of shortage in the healthcare workers that we expect in the next decade. And looking to Africa here, the shortages will be especially acute in the sub-Saharan African countries. If we see that in 47 countries, sub-Saharan African countries, there's just 168 medical schools that exist. 11 countries have no medical schools, and 24 have only one medical school. And it's our commitment as a manufacturer to also help developing educational initiatives for Africa. We can do this with technology, but we can also set up, let's say, collaborations which help in building capacity on health education, creating sustainable business development in Africa. On the one hand, you see there's the local education institutes in Africa. They need to raise curriculum. Also there we can identify deficiencies in the curricula. We see local hospitals in Africa, the governments, the Ministry of Health, of Education that are involved. On the other side, we see the Western world, let's say, where we see that Western education institutes, hospitals are there also to support train-the-trainer approach, sometimes send over people to Africa to help in education. We see some development agencies like GIZ, the German Technical Corporation, the government itself, co-financing they do. And we see, of course, a very important role for the NGOs with, of course, access to co-financing and project support. Now, we as Siemens there, we see that we can play a role in connecting those two worlds, let's say, by giving training, providing equipment, helping in resources, and also knowledge, e-learning, and helping also to facilitate in the co-financing of all of this. My last slide here gives you an overview of some of the initiatives that we did so far in Middle East and Africa. We support technical colleges, for instance, in Ivory Coast and Cameroon, to train students on the latest technology by using the smart simulator that I just explained to you. We do help healthcare institutions in fighting deficiencies, as I said, in the training curriculum. We're also committed to training the local specialists, and we support several technical universities in training of biomedical engineers. One of these examples is in Kenya and Senegal. We have set up together with some other German companies, which are B. Brown, there was Sturt Sysmex, Draeger also was involved there. And with these 5 companies and the GIZ, so the German Technical Corporation, we support development of a bachelor course of studies in biomedical engineering. And I said this was set up in Kenya and Senegal. It is still in progress. It needs also setup of a local lab for the moment, which is currently ongoing in both countries. But just an example to show that we are also active through the German government in this. Also, there's an example, which is the Africa Compt initiative by the German government. Africa Compt means in German, Africa is coming, let's say, and we have already enabled several talents from Africa to do a 1-year internship at Siemens in Germany, followed by a job offering on the African continent. Okay, this is only for few individuals, but still it shows our commitment there. And another one is a partnership with RAD8. You might have heard about RAD8, which is a UN-affiliated NGO with official relations to the WHO, and they aim to improve radiology in underserved countries. And we've set up collaborations with them in projects in Cameroon, for instance, and in other countries as well in Africa. But there, for instance, Cameroon, they have been involved in not installing, but I mean in the training after we installed 11 new hospitals. So now let me conclude by saying that we understand that meeting the global crisis in the healthcare workforce is a challenging one. And but as a global manufacturer of medical technology, we have the responsibility to support our customers in helping their workforce to finally serve their patients in the best possible way. And the only goal they have is to save lives. And this is where we hopefully can play a role for you. This brings me to the end of my presentation. You see my contact details. If anything you would like to know about our offering or about the PEPconnect or PEPconnections, please, I will be happy to help you with this. Thank you so much.
Wow. So a slightly different approach from the others. But I see at the end, you came back to talk about health workforce, what you are doing in training. But the half of the thing was about Siemens. I know Siemens, but let's focus the discussion on how we can solve the health workforce crisis moving forward. Maybe the private sector has certainly a big role to play in all this, and we look forward to that partnership. We just have 15 minutes left to the end of this session. And I would now like to open the discussions to the participants from the chat. I don't see any questions. There are those who we were told that if you put up your hand, you can be given space to speak. Anyone putting up their hand? There are 2 hands. I don't see who they are, but you can start. From the participants, I see 2 hands, but I can't see who it is. But you can come, you can speak, whoever it is that you are. Rosella Michio. Yes, go ahead.
Yes. Hello, can you hear me? I'm sorry, there has to be a problem with the video because I was supposed to be in the panel among the panelists, but there have been some problems. So I actually have also I will try to share the screen because I had prepared a very short PowerPoint. for today's meeting. So if I'm allowed, I will go through very briefly because many things have already been said, but I think it's important to share our first-hand experience in terms of training healthcare workforce in Africa mainly. So if you allow me, well, just basically Emergencies, an international NGO founded in Italy 27 years ago. And we have been working in 19 countries so far, treating over 11 million people and training over 10,000 local staff members. Of course, we have all acknowledged the importance of developing a strong and resilient health workforce. The SDG 3 is reminding us the importance of the development, training, and retention of the health workforce in developing countries particularly. But from the estimate of the WHO, we see that the gap, the shortages are going to increase, particularly in Africa. We see here that all the metrics will slightly improve for the other regions while we get worse for the African continent, unfortunately. What has been our approach so far? First of all, we believe that the right to health is a fundamental human right, and therefore we believe that it has to be based on the concept of equality, quality, and social responsibility. This, in practical terms, means that we have always aimed at providing free access to medical and surgical care. Then we have focused on the medical excellence, so on the quality of the services provided, which means that people have the right to the best treatment made possible by the progress of medical science. But at the same time, we need to work to strengthen the health systems and make it many-layered, including secondary and tertiary healthcare facilities, to complement the primary health sector. And of course, a key aspect is the training for healthcare workers. So we have always promoted the training of qualified healthcare workers. Through our hospitals, through centers of excellence, we can contribute, we believe that we can contribute to tackling this healthcare workforce crisis, reducing the brain drain phenomenon and strengthening at the same time the local healthcare system. How do we do it? We invest in specialized training for medical staff through agreements with the ministries of health, local university, education institution, to create new generation of doctors, nurses, and other healthcare professionals. But at the same time, we also do on-the-job training for medical and non-medical staff, because we need that the hospital setting is something that is quite complex and requires a lot of professional skills. Just two very quick example of success stories, what we consider success stories, and we propose as possible models, is what we call the African Network of Medical Excellence. That is a network established back in 2009 together with the ministries of health of several African countries, identifying health gaps in each country that could be shared with the neighboring countries, and to provide not only high standard, high quality healthcare to the patients of those countries and the other participating countries, but also to invest in training of health workforce. The first example was in Sudan with the Salam Center for Cardiac Surgery, where we provide since 2007 free of charge cardiac surgery. The center is fully equipped with 3 theaters, 15 beds intensive care unit, 16 sub-intensive care, and all the ancillary facilities, including an anti-coagulation clinic for the patients follow-up. We employ there 490 local staff, 270 of whom are medical, nursing, and other kind of healthcare workers, ranging from pharmacists to radiologists, lab technician, and so on, biomedical engineer, and so on. And for all of them, we have provided on-the-job training. These are basically a few numbers of the clinical activities that we've been able to do together with our colleagues. Out of 409 local staff, we have approximately 50 international staff that are working together. The Salam Center is at the heart of a regional program, and that is guaranteeing free access to cardiac surgery also to patients coming from other countries. And we have, at the moment, we have received 50 residents and students to be trained at the Salam Center, because in 2017 we were recognized by the Sudanese Medical Specialization Board and were embedded in the national specialization program, and we are now developing with them other new ways for training, including fellowships and new curricula for other health professionals. And what I'm very happy about is that
there are many hands up. I was not expecting another presentation, so maybe you could find a way so that we
absolutely
have other people. We
just
have
to
only
say that
6 minutes left.
Okay, we are just having hopefully by next fall also some physicians from Uganda to join at the Salam Center to be trained there, and this is something that we are very happy about. The same model we are implementing in Uganda now, but on a different specialty, which is pediatric surgery. And the same approach in joining forces with the ministries of health, but also with other local institutions in Africa, including COSEXA and GICS. Therefore, most of the conclusions have already been said, particularly by Vanessa before, and this is just a suggestion for a potential collaboration between local institutions, international institutions, and NGOs to work together to strengthen the health workforce, providing quality training, in-country training to improve the overall health systems of the country. Thank you.
Well, thank you. But we have a big problem. I wasn't expecting additional presenters, and I don't know what is going on now. There is a hand up. Veronica, was it Harriet Nakigozi?
Yes, it was Harriet, yes. Thank
Please,
you so much
quickly.
for that. Yeah. I'm going to be brief. I was wondering, because from the presentations, I noted that we are anticipating a global burden of shortage of health workers by 2035. And already we are seeing the crisis of COVID. So how are we planning, or what plans do we have? Because I've seen the presentations from Patrick, it is elaborating that they have some of these things on board. But it so happens because most of these health workers, some of them are not knowing some of these opportunities where they can be captain. But eventually, I'm seeing also going to be a lot of brain drain from these sites, like Africans, especially Ugandans, because people are looking for greener pastures. So how are we ready to handle that, more especially as Ugandans? Thank you.
Let me pass that question to Graham and Vanessa quickly. We have got 4 minutes now. Graham, can you go first?
Thank you for the question. I think headlines to address the HRH crisis. I think we need to prioritize education, training, most critically employment of health workers, and win that argument. This is not only in the economic interest, but also in the wider interests of all our societies. We also need to accept that mobility of health workers is here to stay, and so we need to ensure countries like Uganda and others don't lose out. And we need to protect individual health workers' rights. But I think we need to go further than that. I think we need to ensure that mobility can potentially act as a multiplier for training and employment in sending countries. And only then, amongst other ingredients, can we aspire towards sustainable workforces for all.
Thank you. I think that from our standpoint at Seed Global Health, there's, we are aware as we're partnering with governments to train healthcare workers, the retention and absorption piece is really critical. And so, it is indeed healthcare workers, there's going to be mobility and it's a human right to be able to, live where you want to. But the reality is that as we think about what the push factors are that might drive people from the healthcare workforce, those are the places that we might be able to pull levers. Not all of it is salary. Some of it is the ability to have schools for your children. It is the ability to have continuing professional development, to be able to practice what you train in and to have the tools of your trade. And so the approach that Seed has taken is to try to, from the work we do on the ground, then work with governments to think about what is the path forward for those pieces, absorption, ensuring that the environment that folks can work in or healthcare workers work in is empowering, can boost morale. There's data that shows that people are more likely to stay and work in the places where they train. So if you equip them to work in these places, they're more likely to stay there and to work as well. And so we have to see this as very holistically, but I think that by working closely with governments to think about how are we going to absorb those that are trained and the importance of not losing that investment and creating that argument can be a key path to that absorption and retention. And certainly thinking about what is the work environment that healthcare workers have to be protected and empowered is critically important, as well as ensuring they're paid. And that is going to be where we're going to have to get into some global discussions about mobilizing capital to ensure that there's capital available to absorb these healthcare workers and to support them in the communities where we need them most.
Correct. There's another hand up there, Gracious. Let's hear you.
Thank you for the presentation. And my question goes to Patrick. In Sub-Saharan Africa, you mentioned that very many countries have only one medical school. I think you mentioned 24. What are the challenges that lead countries to not be able to increase the number of medical schools? Because in some places where we have quite a number, for example, in Uganda, if I remember clearly, we have about 8 medical schools, but we also feel that there are so many. Thank you. Over.
Patrick? You are muted. I can't hear you. It seems you are not muted, but something, take people, what's happening? Can you allow Patrick to speak? Oh, something is wrong. I don't know whether with your system or while we are sorting that one out. Wamala, can you ask your question quickly? Wamala? Otherwise, the time we are allocated for the session is over. And I would just like to summarize by saying that this topic remains key to the future for achievement of sustainable development goals and universal health coverage and access to basic health care for all people, issues of equity and social justice. And we need to go back to our values and to mobilize the momentum that already exists so that we can ensure that every person in every village has access to a skilled, motivated, and skilled health worker, working together with the private sector like the Siemens and others. We should be able to do this, but the job is still big and we still have a lot of work to do. Thank you everyone for taking the trouble, the presenters for making your presentations. And Rosella, I had not been told about you, I'm sorry. Let's continue. We have each other's contact. Let's continue the dialogue outside this meeting. So thank you very much indeed. I want to be disciplined and not disrupt the program and end the meeting there. Thank you very much indeed, everyone. Let's follow up.